Practicing medicine in the United States and in Ethiopia feels like two completely different worlds. The resources are different, the expectations are different, and to a certain extent the diseases are different. As a physician who was trained in Ethiopia and came to the United States, received further training, and started practicing here, I have first-hand experience of both systems. Today I'm coming to you to share my experience in the difference between the two systems, what challenged me, what surprised me, and what each system does better. My name is Dr. Ermias Grafi. I am a hospitalist, board-certified internist practicing here in the United States, and we'll dive in. In Ethiopia, especially in public hospitals, resources are very limited. You don't have access to advanced diagnostics, rapid diagnostics, sometimes even basic labs are a luxury, and therefore you rely heavily on your clinical exam, your history taking, your bedside skills, and pattern recognition. In the United States, resources are abundant. You can get imaging at the tip of your finger, advanced lab tests, diagnostics, therapeutic options, subspecialty consults. But the problem with this is sometimes we overuse them. So in Ethiopia, I learned to trust my clinical exam. In the United States, I learned to confirm everything with the data. I am so proud to be trained in Ethiopia, especially in Gondar University, because it gave me a firm knowledge and art of medicine. I was trained to diagnose patients in resource-limited setup. So every problem had its own silver lining. The fact that we didn't have the resources made us use and develop our clinical exam skills. The second one is regarding EMR and documentation. In Ethiopia, documentation is simpler. Back in the days when we trained, we used the paper system, so we have to write everything, and we tried to do our best, but documentation was not heavily emphasized. In the United States, documentation is everything. If it's not documented, it's not done. First, you have to learn the EMR, which is kind of a little bit complex by itself. Then you have to learn how to document properly, because documentation is not just for you to review or for the other physician to know what you did for the patient. It is for billing purposes. It's for quality improvement. It's a legal document. So, this was a big adjustment for me personally. And sometimes in the United States, as physicians, we spend more time documenting than delivering care to the patients. This has its own positive and negative sides, I guess. Fourth one is about team structure and specialization. In Ethiopia, internists manage broad cases because you don't have access to subspecialists, right? So you have more independence. In the United States, you have subspecialists for everything. And so you are expected to consult the subspecialists for everything. So it's cardiologist for shortness of breath, nephrologist for elevated creatinine. So everything you are expected to consult. Of course, you can have your own opinion, and you can start the management, but the system expects you to consult the most appropriate and qualified person on that field to see the patient before you discharge them from the hospital. It's also part of the defensive medicine that we're going to discuss later. It is good for the patients sometimes because it's very organized, and the patients get to be seen by the most experienced, the highly specialized person in the field. But again, as internists, sometimes you feel like you're just coordinating the care. You feel like the system is very organized, but also sometimes fragmented. So you are the one that's holding everything together. In the United States, there is this thing called defensive medicine. There is a huge issue of malpractice and fear of litigation among physicians. As a physician, you don't want to be sued or named in any case. Therefore, you have to make sure that you have done everything and documented everything in case things go south. You have to make sure that you have covered your ass in case something happens or something goes wrong. For example, a patient who comes to the emergency department with a simple chest pain, which you think or almost 100% sure that it's musculoskeletal because it's reproducible by palpation, it's on the chest wall, They will end up getting a CTA chest, 2 or 3 troponin tests, EKGs, echocardiograms, and all that to rule out any life-threatening complications, because God forbid, if that happens, you are toast. In Ethiopia, the limitation is not litigation, it's access. You have to think twice before you order a test for the patient, because they might not afford it and it might be very expensive. And the information that you get out of it may not be justified. So it may not be cost effective for that patient. And this shapes your clinical judgment differently in the two systems. The fifth one is disease pattern differences. In Ethiopia, infectious diseases predominate, right? You have TB, malaria, HIV, and you also see very advanced presentation of some chronic non-communicable diseases or cancer. In the United States, you see more chronic disease, you see more aging population with multiple comorbidities, or people living in nursing homes, or people coming with like polypharmacy. The average 70 years old in the United States probably takes 7 or 8 medications daily. And it's also amazing to see how many people survive, different cancers, for example. Sometimes, on paper, in Ethiopia, for example, if you have a paper documentation saying the patient has stage 4 breast cancer with this and that, you'd expect a very debilitated, a very emaciated, patient, right? But here in the United States, you might have a documentation saying patient has stage 4 breast cancer, stage whatever, colorectal cancer, taking chemo, radiation, and whatnot, and the patient will come, does not appear sick. They're sick, but they don't appear sick. They're walking to you, they're fine, So this was like a huge difference for me as well. So the sixth point is differences in patient expectations and culture. In Ethiopia, there is deep respect for physicians, and there is less expectations due to the resource realities, at least in the rural parts of Ethiopia. I mean, in the capital cities and in the major cities, this could be changing because of the booming economy and availability of resources nowadays. But for the other parts of Ethiopia, this is still the reality. In the United States, this is very different. Patients have high expectations from you, and they have great autonomy, so everything is a shared decision making between you and the patient. They have legal awareness, and their health literacy is undeniably high. Therefore, there is a lot of expectations from patients. What each system does better. Each system has its own weakness and strength. I feel like the significant strength of training and practicing in Ethiopia is that you develop your clinical skills, and you develop a great deal of resilience in practicing medicine in resource-limited settings. That is a major benefit that you get in training in Ethiopia. How about in the United States, practicing medicine in the United States? Well, here you have more structured, advanced, and protocol-based treatments. It's good patient safety and quality improvement systems in place, access to advanced therapies, access to resources. My personal reflection on this is that in Ethiopia, it taught me clinical judgment, humility, and clinical skills and adaptability in being able to work in resource-limited settings. In the United States, it taught me systems-based thinking, protocol-based treatments, evidence-based rigor, and structured patient safety. And I'm very grateful for both systems. If you are an IMG navigating the United States health system, know that your background is a strength and not a weakness. Global medicine creates stronger physicians. Let me know in the comments, where do you practice? What differences have you noticed? And what is your biggest challenge? If you are a physician who is currently practicing in Ethiopia or any other country who's planning to come to the United States, if you feel like you want to ask me questions, you can drop them in the comment section. I will get back to you. I will probably make another video on this topic. But don't forget to like the video and subscribe to the channel. And until my next video, thank you. I'm out.